Hi, everybody. My name is Alejandro Gabutti. I'm interventional radiologist in Mexico City, and today I'm going to talk about liver-directed therapies in the context of a neuroendocrine tumor. So, what matters most to make your next best decision? For sure, knowledge. First of all, thank you for listening to me, and thank you for giving me the opportunity to explain why interventional radiology can offer. So, let's get started. First of all, my full name, it's Alejandro Gabutti Thomas. I'm from Mexico. I got my medical degree by the UNAM, that is the National University of Mexico, and I got training in radiology and interventional radiology in a public hospital in Mexico City called Instituto Nacional de Nutrición or National Institute of Nutrition. I also have an internship in Milan, Italy, focused on liver cancer. And today I work in the same hospital where I got trained, Instituto Nacional de Nutrición in Mexico City. So what is a liver-directed therapy? It is a medical procedure done by an interventional radiologist. The therapeutic effect only occurs locally in the liver, so no systemic symptoms or effectiveness. It could be very helpful in the treatment of liver metastases for sure. But wait a minute, can a radiologist do treatments? Most of the radiologists mainly do reports of different imaging modalities. They are always behind a screen in the dark, and there are plenty of jokes about their social skills, like comparing radiologists to a vampire. But the interventional radiologists, we are a little bit different. We love the light and talking to people. So we initially are all conventional radiologists, but then we got trained using the imaging techniques to guide interventions. Interventional radiology procedures characteristic is that they are minimally invasive, most of them through a very small puncture of 2 millimeters. They are really well tolerated, fast recovery after the procedure, and can be also really effective. But are interventional radiology procedures for everyone? The answer is not always. The patient should be evaluated by multiple specialists. A clear benefit from the procedure should be achieved, and there are some technical criteria to consider for sure. And how it's possible to execute a procedure within the liver just with a small puncture, that was my face when I was a medical student and someone explained me for the very first time what an interventional radiologist can do. So let's make it simple. We use the ultrasound, the X-rays to mainly see inside your body, okay? So this allows us to place a medical device in a very precisely way in order to deliver a treatment locally. It's better to explain with example. So I introduce to you our enemy, a single liver metastasis. This round-shaped lesion within the liver that it's white, shows enhancement with contrast. We use the ultrasound to localize what we found in the CT scan and then to place a needle in a very precisely way. As you can see, we work looking not the patient, but the screen of the ultrasound. This is the percutaneous liver-directed procedure. Go through the skin into the liver. If I use a biopsy needle, it will be called a biopsy. But if I use a therapeutic device, it could be called an ablation. But sometimes it's not easy to find things with ultrasound, so we can also use a CT guidance to place my needle in a very precisely way. When we are under a CT-guided procedure, we can lay in the CT scan in different positions, so it's normal also during the procedure to change a little bit our position. But sometimes we don't have just a single metastasis. We have multiple metastases within the liver, and it's not possible or safe to puncture everyone. Can you imagine to make 20 or 30 punctures into the liver? It will not be comfortable for our patient. But we have an alternative way to reach them, an endovascular procedure. So we use the arteries as a roadway to get into the liver and then find the vessels who feed this metastasis. The access site is almost always in our right wrist or in the right groin. These kind of procedures are performed in a cath lab that is the same one that the cardiologists do to treat myocardial infarction. We use X-ray guidance and we do an angiography of the hepatic artery. So we use contrast media to depict the whole artery who is feeding the liver metastasis. So far by now, we know how interventional procedures are done. There are two main groups, as we saw, the percutaneous and endovascular. But how do they actually work? First of all, let's go back to the ablation, a single metastasis scenario. We put our needle, in this case ablation probe, and we deliver energy. Could be heat, could be cold, could be an electric current. The point is to destroy the tumoral tissue. And in the CT scan, you see how now the tumor looks dark, no enhancement, and that means tumor death. So the percutaneous interventions as ablation can be very effective. Good candidates, those patients with 1 to 3 tumors no larger than 3 centimeters. Ideal candidates, patients who has just 1 tumor who measures less than 3 centimeters. In this scenario, ablation could be as good as surgery. So it's a very, very good alternative because fast recovery, almost just 1 day hospital stay, and no wounds at all. Unfortunately, this scenario of a single metastasis in the neuroendocrine ambience is not really common. Moving to embolization or endovascular interventions, embolization means to occlude a vessel. But wait a minute, doesn't blocking a blood vessel cause an infarct? The answer is yes, but the normal liver is the exception. Why? Because the liver has a dual blood supply. Okay, we have the portal vein and the hepatic artery. So if we close the hepatic artery very distally, very close to the tumor, we still have the portal vein who supplies enough blood to avoid an infarction in the kidney. But guess who doesn't have a single vascular supply? The liver metastasis. So we can occlude this artery or this branch of the hepatic artery as a therapeutic weapon to treat our metastasis. So once the catheter tip is placed as selective as possible within the hepatic artery, especially the artery who is feeding the metastasis, we can deliver 3 types of therapeutic agents: just embolization, chemioembolization, or radioembolization. I should mention that nowadays chemioembolization is under investigation because of safety reasons. And it was really common to perform chemioembolization in neuroendocrine tumors, but nowadays we are keeping it out from our first choice as treatment. So further research must be done. So embolization is the main active of these endovascular therapies because they cause the tumoral infarction and tumoral death. So embolization, this treatment could help us to stop the tumoral liver progression. Tumor-related symptoms may also improve after embolization as hypertension, hypoglycemia, or diarrhea. And the embolization is an on-demand treatment, so we can receive as many as possible until we have normal liver function. The different techniques as TIE, TACE, or TAR are considered equivalents, but as I said, nowadays TACE is under investigation because of safety reasons. And healthy arteries are mandatory. As I explained, the arteries are our road to reach the tumor. So if we have problems with arterial circulation or arterial surgeries previously, may impair how we can reach the tumors within the liver. Okay, now I'm going to answer some of the most common questions that my patients ask me. First of all, are liver-directed therapies painful? The answer is no. During the procedure, local anesthesia, sedation, or occasionally general anesthesia help us to avoid the pain. But after discharge home, conventional painkillers are usually enough to treat residual pain or discomfort related to the treatment. Are liver-directed therapies safe? Yes, but special orientation should be taken in fragile patients, especially elderly patients, okay? Also, hormonal-related symptoms may increase transiently after the procedure. Think the tumor is a hive, and the bees are the hormones. What happens if we hit the hive? A lot of bees will come out, okay? So the symptoms may worsen. But at the end, the hive will be destroyed and no more bees will be able to come out. That's a little bit how it works. And before any interventional radiology procedure, a multidisciplinary board should assess carefully the case, including the safety profile, and should say it's okay to go ahead. Post-embolization syndrome is something unique that happens with the arterial-directed therapies as embolization. It will happen 24 to 48 hours after an endovascular therapy. Fever, nausea, and abdominal pain are the most common symptoms, and usually it's self-limited and could be managed symptomatically at home. But special attention should be put when we treat bulky disease, big tumor, big infarct, so a lot of symptoms could come out after the treatment. How fast is recovery after a liver-directed therapy? Most of the procedure could be done with a short hospital stay, maybe just one night. And in some selected cases, it could be done as an outpatient way with just local anesthesia, especially when the patient has low tumoral burden, there's a radial access, and a good performance status, so a very strong patient. No special care should be taken after the procedure because, as you know, the wound it's really small. It's 2 millimeter puncture, like when we have a blood sample. So there's no need to have rest for a long time at bed or to cover a wound for a long time. And return to normal activities sometimes takes very few time, like 24 to 48 hours post procedure. But every case it's different, okay? So we have to individualize what the symptoms or the complications may be treated or expected in a patient. So take home points of what matters most to make your next best decision, to know that liver directed therapies are really effective. Patient selection is mandatory to guarantee a good safety profile. Ablation may compete in effectiveness with surgery, especially in a small single mets scenario. Vascular or endovascular procedures may improve the hormonal related symptoms as diarrhea, hypertension, or hypoglycemia. Recovery after an interventional radiology therapy is really fast, and treatment related symptoms could be managed at home. To decide to get liver-directed therapy doesn't exclude you for a different treatment in future, and that's something really important to recognize. Thank you very much.